General surgery guidelines. Okay. Surgery procedure. Surgery is defined as the art practice or work of treating diseases, injuries, or deformities by manual or operative procedures. Procedures may be invasive or non invasive, i.e., closed fracture care, and may include instrumental applications to treat such cases. Surgeries are further classified as minor or major procedures. Minor procedure examples include ear wax removal, diagnostic scope, or joint injection. Major procedure examples include knee replacement or spinal fusion. General surgery guidelines. Surgery codes are found in the series 10,000 and 21 69,979. Each section is split into chapters that are defined by the system operated on and categorized by how the procedure is being performed. Excision, incision, repairs. The systems represented are as follows: integumentary system 10,020, 1 minus 19,000, 499 musculoskeletal system 20,000 and 5 minus 29,000. 999 respiratory system 30,000 minus 32,000. 990. 9 cardiovascular system 33,000 and 10 minus 37,000. 790. 9 digestive system 40,000. 490 minus 49,000. 990. 9 urinary system 50,000 and 10 minus 53,000. 899 male genital system 50. 4,000 minus 55,000. 899 reproductive system procedures 55,000. 920 intersex surgery 55,000. 970 minus 55,000. 980 female genital system 56,000. 405 minus 58,000. 990. 9 maternity care and delivery 59,000 minus 59,000. 890. 9 endocrine system 60,000 minus 60,000. 699 nervous system 61,000 minus 60. 4,999 eye and ocular adnexus 65,000 and 91 minus 68,000. 899 auditory system 69,000 minus 69,000. 979 code 60. 9,000. 990 is used to report an operating microscope and may be reported independent of the surgical procedure when the microscope is used during surgery. Regardless of the specialty for which you are coding, there are general guidelines that must be followed. CPT provides special guidance on appropriate coding for add on codes, separate procedures, and surgical package. Add on codes are procedures carried out in addition to the primary procedure performed. The add on code cannot be billed independently. Add on codes are also exempt from the multiple procedure rule and therefore cannot be billed utilizing the 50(1) modifier multiple procedure. Since the add on procedure is billable in addition to the primary procedure and considered separate, the reduction in reimbursement given to multiple procedure services is not applicable. Add on codes can be easily identified with descriptions, which include phrases such as each additional, or where the procedure directs the coder to list the procedure separately in addition to the primary procedure. Example 17,000 destruction of lesion any method. First lesion primary code 17,000 and 3 destruction of lesion any method. 2 minus 14 lesion add-on code. The code symbol for add-on codes is a phi in front of the numeric CPT procedure code. Add-on code should never be coded independent of the primary code or as a standalone code. Separate procedure codes are listed as such in parentheses after the numeric procedure code. There are two instances where separate procedures are utilized. The following guidelines should be followed when billing for procedures that are listed as separate procedures. Some procedures listed in CPT are carried out as an integral part of another procedure or service and as such are designated as separate procedures. In these cases, the separate procedure should not be reported in addition to the service of which it is considered an integral part. An example of this would be surgical services listed as diagnostic surgery. All diagnostic surgeries listed as primary component codes are listed as separate procedures and therefore may be billed only if they are the ONLY service that is performed in that series of codes. If the diagnostic service is performed, and there is no other surgical procedure performed, repair due to the fact that no confirmation or a diagnosis is developed, then the diagnostic service is billed as it is the only service performed. If a diagnostic procedure is performed and during the course of the procedure a diagnosis is confirmed and then a procedure is performed repair, then the diagnostic portion is an integral part of the primary procedure performed and therefore only the procedure performed should be coded. Example 1, Disa Smith schedules Ethel for a diagnostic knee arthroscopy as she has had knee pain for 6 months. The patient had been to physical therapy and had joint injections, yet the pain had not resolved. Disa Smith performs the diagnostic knee arthroscopy and finds no abnormality of the knee except for some inflammation. The procedure is completed and the physician bills for the diagnostic arthroscopy as it is a standalone procedure and no other service was performed. The accurate code would be 29,870. Example 2, Dessa Smith performs the diagnostic knee arthroscopy and upon review of the knee finds a medial meniscal tear. He performs a medial meniscal repair. The diagnostic arthroscopy procedure is an integral part of the surgical procedure. The physician had to do the diagnostic portion to determine that there was indeed a tear. Therefore, the diagnostic portion is inclusive of the actual repair and cannot be billed in addition to the procedure. This surgical procedure would be coded as 29,882. The examples above explain each scenario and how to bill for separate procedures where the diagnostic surgery is the initial procedure performed. Remember, when a diagnostic surgery is performed initially to determine if there is a problem and results show there is nothing that requires further surgery, the diagnostic service is billed as it is the only procedure performed. If the diagnostic service is performed and results show a problem, then the diagnostic service becomes an integral part of the surgical procedure performed to correct the problem, and therefore the diagnostic separate procedure is not billed separately. Only the corrective surgical procedure would be billed. Other procedure codes listed as separate procedures may be carried out at the same session as other procedures but may be considered separate and independent of the primary procedure performed and would be billed as a separate procedure in addition to the primary procedure. These separate procedure codes are considered unrelated to other procedures performed at the same time. The modifier 59 should be appended to the specific separate procedure code to show that the procedure is separate and distinct from the other procedures performed and is not considered to be a component of the other procedures performed. A procedure may be reported separately for cases where the separate procedure was performed during a different session, a different site or organ system, different procedure or surgery, separate excision incision, separate lesion, or separate injury or area of injury in extensive injuries. Example 1, Dr. Smith is performing a cranioplasty on a patient and drill burr hole so that he can implant a ventricular catheter. The burr hole is listed as a separate procedure as it is a significant separately identifiable procedure. The surgery would be coded as follows: 62,140, 61,210. Separate procedure. Example 2, Dr. Jones performs a diagnostic colonoscopy on a patient, which results in the decision to perform an open procedure of the abdomen. Since the diagnostic colonoscopy was performed as a separate distinct procedure from the surgical procedure performed different locations, both the diagnostic colonoscopy 45,378 separate procedure as well as the open abdominal surgery 49,020 should be coded. A diagnostic procedure is a procedure performed for the purpose of determining a diagnosis of a patient or for investigational purposes to rule out certain conditions. Diagnostic procedures are not performed to treat or cure a condition. When follow up care for diagnostic procedures is performed, i.e., diagnostic endoscopy, arthroscopy, all care provided after the procedure related to the performance of the procedure itself is not reported separately. Care not related to the diagnostic procedure may be reported separately. A therapeutic procedure is a procedure in which the patient experiences relief from a symptom, a stop to the progression of a disease, or some other short or long term benefit. When follow up care is provided for therapeutic surgical procedures, the care related to the therapeutic procedure is not reported separately. Additional services provided as a result of complications of any sort are reported separate from the therapeutic surgical procedure. When performing surgery procedures, there are some supplies and other materials that may be reported separately when they are not a part of the normal services provided for the surgery. Surgery trays and drugs utilized during surgery are just some of the services that may be reported separate from the surgery procedure. Three rules apply to global surgery for minor and major procedures. These rules are defined by CMS as follows: 0-day post operative period endoscopies and some minor procedures. No preoperative period. No post operative days. A visit on day of procedure is generally not payable as a separate service. 10-day post operative period. Other minor procedures. No preoperative period. Visit on day of the procedure is generally not payable as a separate service fee. Total global period is 11 days to include the day of the surgery and 10 days following the day of the surgery. 90-day post-operative period. Major procedures. 1 day pre-operative included third day of the procedure is generally not payable as a separate service as a total global period is 92 days, counting 1 day before the day of the surgery, the day of surgery, and the 90 days immediately following the day of surgery. To obtain global periods for surgery, visit the CMS website at surgical modifiers are utilized to modify certain circumstances for services provided. CPT modifiers are two-digit numeric CPT modifiers or alphanumeric and alpha-alpha codes, each CPC is placed after the usual procedure number. The modifier modifies the procedure code on which it is attached without changing the actual description of the service that is being provided. A full list of CPT modifiers can be found in the front cover of the CPT book, and each CPCS modifiers can be found in the each CPCS level II book. The following CPT modifiers may be appended to surgical codes to modify the procedure. 22 Unusual procedural services when service provided is greater than that usually required for the listed procedure. Minus 40. 7 Anesthesia by surgeon. Regional or general anesthesia provided by the surgeon is reported using modifier 40. 7 Do not use with codes 100 minus 1999. Minus 50 Bilateral procedure services provided that do not indicate bilateral procedure in the code description and are performed at the same operative session. Utilize the modifier 50 to indicate that the procedure was performed on both areas. Minus 50. 1 Multiple procedures when multiple procedures not AM are performed at the same session or on the same day by the same provider. The primary procedure is listed first and all subsequent procedures are reported utilizing this modifier. Minus 50. 2 Reduced services under certain circumstances. Some procedures are partially reduced or eliminated at the physician's election. The modifier 52 should be added to these services. Minus 50. 3 Discontinued procedures. The physician may elect to terminate a surgical or diagnostic procedure due to extenuating circumstances or those that threaten the well being of the patient. It may be necessary to indicate that a surgical or diagnostic procedure was started but discontinued. 50. For surgical care only when a physician performs a surgical procedure and another provides preoperative and/or postoperative management. Surgical services may be identified by adding modifier 54. Minus 50. 5 Postoperative management only when one physician performs the postoperative management and another physician has performed the surgical procedure. The postoperative component is billed utilizing the 55 modifier. Minus 50. 6 Preoperative management only when one physician performs the postoperative management and another physician performs the preoperative component only. Modifier 56 is used on the surgical procedure code. Minus 50. 8 Staged or related procedure or service by the same physician during the postoperative period. The physician may need to indicate that the performance of a procedure or service during the postoperative period was planned prospectively at the time of the original procedure, staged, more extensive than the original procedure, of a therapy following a diagnostic surgical procedure. Minus 59 Distinct procedural service. The modifier 59 is used to identify that a procedure or service was distinct from another procedure or service performed on the same day. In 2015, CMS added 4 new modifiers to better describe distinct separate services. These modifiers will replace the minus 59 for Medicare patients only. All other payers will still recognize the minus 59 modifier when reporting distinct, separate procedures performed at the same session by the same provider. In 2015, Medicare developed new HCPCS level II modifiers to further define minus 59 separate procedure scenarios. Do not use minus 59 and any of the following modifiers together on the same line item. XE separate encounter a service that is distinct because it occurred during a separate encounter. X as separate structure a service that is distinct because it was performed on a separate organ structure. XP separate practitioner a service that is distinct because it was performed by a different practitioner. XU unusual non-overlapping service the use of a service that is distinct because it does not overlap usual components of the main service. Minus 60 to 2 surgeons. When the skills of 2 surgeons are required in the management of a specific surgical procedure, modifier 62 should be used by both physicians performing surgery. The physicians are usually of different specialties. 66 surgical team high complex procedures sometimes require the services of several physicians, often of different specialties, under the surgical team concept. Such services are identified using the 66 modifier. Each physician would utilize the modifier for services that they bill. Minus 70. 6 repeat procedure by same physician. When a physician must indicate that a procedure or service was repeated subsequent to the original service, the modifier 76 should be used. Minus 70. 7 repeat procedure by another physician. When a physician must indicate that a procedure or service that was performed by another physician was repeated, the procedure should be billed with modifier 77. Minus 70. 8 return to operating room for related procedure during postoperative period. The physician may need to indicate that another procedure was performed during the postoperative period of the initial procedure. When the subsequent procedure is related to the initial procedure, modifier 78 would be appended to the second procedure performed. Minus 70. 9 unrelated procedure or service by the same physician during the postoperative period. The physician may need to indicate that the performance of a procedure or service during the postoperative period was unrelated to the original procedure. The modifier 79 would be utilized when billing the subsequent unrelated procedure or service. Minus 80 assistant surgeon. When surgeon uses an assistant surgeon use minus 80 modifier. Minus 80. 1 minimum assistant surgeon minimum assistant surgery services are reported using the 81 modifier. Minus 80. 2 assistant surgeon when qualified resident surgeon not available. When a resident surgeon is unavailable or unqualified to assist in surgery, the modifier 82 should be utilized on the services billed by the surgeons. Minus 90. 9 multiple modifiers under certain circumstances, more than 2 modifiers may be necessary to code the service completely. The following HCPCS level II modifiers are also used for surgery section E1 upper left, eyelid E2 lower left, eyelid E3 upper right, eyelid E4 lower right, eyelid LC left circumflex coronary artery LD left anterior descending coronary artery LSFDA monitored intraocular lens implant LT left side PA surgical or other invasive procedure on wrong body part PB surgical or other invasive procedure on wrong patient PC wrong surgery or other invasive procedure on patient RC right coronary artery RT right side. Surgery subsection guidelines in addition to the surgery section guidelines that affect all surgery procedure codes. There are additional subsection guidelines that provide special guidance for specific code categories. These subsection guidelines will provide additional instructions regarding things such as what services are reported separately and what services are considered bundled into the main surgical procedure. Any surgery section that does not have subsection guidelines should be coded using the overall section guideline instructions for the surgery section as defined in the green pages before the CPT surgery code listing. The following surgery specialties have subsection guidelines. Integumentary system surgery guidelines surgeries related to skin, glands, hair, and nails are reported in the integumentary system. Debridement is the removal of damaged tissue or foreign body from a wound. Debridement codes 11,000 and 40. 2 minus 11,000 and 47 are reported by depth of the tissue that is removed and by the surface area of the wound. When a single wound is debrided, report the code that describes the deepest level of debridement performed. When more than one wound is being debrided, code the total sum of the surface area of wounds with same depth and report appropriately. Biopsies are the removal and examination of tissue in order to establish a diagnosis. There are a number of different types of biopsy procedures, the most common of which are defined below. Aspiration biopsy biopsy in which tissue is obtained by application of suction through a needle attached to a syringe. Brush biopsy biopsy in which cells or tissue are obtained by manipulating tiny brushes against the tissue or lesion in question, e.g., through a bronchoscope at the desired site. Cone biopsy biopsy in which an inverted cone of tissue is excised, as from the uterine cervix. Core needle biopsy with a large hollow needle that extracts a core of tissue. Endoscopic biopsy removal of tissue by appropriate instruments through an endoscope. Excisional biopsy of tissue removed by surgical cutting. Incisional biopsy of a selected portion of a lesion. Needle biopsy in which tissue is obtained by puncture of a tumor. The tissue within the lumen of the needle being detached by rotation and the needle withdrawn. Also called percutaneous biopsy. Punch biopsy in which tissue is obtained by a punch. Shave biopsy of a skin lesion in which the sample is excised using a cut parallel to the surface of the surrounding skin. Stereotactic biopsy of the brain using stereotactic surgery to locate the biopsy site. Lesion removal procedures are reported by adding the size of the lesion itself plus the margins around the lesion that require surgical removal to excise the lesion. Closure of the surrounding tissue may be reported separately if the closure requires intermediate or complex repair. Simple repairs are considered inclusive of the removal process and therefore are not reported separately. Providers must document the diameter and margins in order to code lesion removal procedures. One repairs are reported by anatomic site, the length of the wound, and the type of repair. There are three types of repairs defined by the complexity level of the repair performed. Simple repairs are considered an integral part of the procedure being performed and therefore are not reported separately from another procedure. However, if the repair is the only procedure being performed, simple repairs are reported. The repair types are defined below. Simple repairs are reported when a single layered closure is performed that involves the epidermis, dermis, or subcutaneous layers of the skin, where there is no deeper layer involvement required to perform the repair. Local anesthesia. Chemical and electrocauterization procedures are considered inclusive of the simple repair procedure and are not reported separately. Simple ligation of vessels and simple exploration of nerves, blood vessels, or tendons is included in the wound repair procedure. Simple repair closure is bundled into the excision codes. Intermediate repairs are reported when the repair involves layered closure of the deeper layers of the skin and the connective tissue, called fascia, that supports muscle and other tissues. Intermediate layer closure may also be reported when a single layer closure is infected and requires extensive cleaning and removal of foreign body or infection before closing the wound. Complex repairs are reported when the repair involves multiple layered closures beyond skin and connective tissue into muscle and other tissues. Complex wounds include wounds that require extensive undermining, debridement, stents, or retention sutures before closing the wound. The top single layer of the skin, the secondary or intermediate layers of the skin, and the deeper layers of the skin are shown in the illustration below. By comparing a provider's documentation verbiage to the layers shown below, the coder can better understand which repair code to assign. The lengths of the wound repairs that are in the same category, simple, intermediate, or complex, and body area should be added together to determine total size of the repair. Example documentation states that the physician performed a simple repair of a 2.5 cm abrasion on the neck and a simple repair of a 3.4 cm laceration on the back. The length of these wounds may be added up and billed as one simple repair. The correct code would be 12,002 since the neck and back are included in the procedure code definition. Example, the documentation in this scenario states that the physician performed a simple repair of a 2.5 cm abrasion on the lip and a simple repair of a 3.4 cm laceration on the back. Notice the category of the wounds has not changed, but the anatomic sites have. Therefore, two codes would be used to code the simple repair in two different anatomic sites. The correct codes would be 12,002 and 12,011. The lengths of the wound repairs in different categories or classifications should always be reported separately. For example, a complex repair and a simple repair must be coded using two separate codes. The more complex classification should be reported as the primary procedure as it requires more time and effort. The minus 50. One modifier would be applied to the second and subsequent codes. Example documentation states that the physician performed a 2.5 cm complex repair of the forearm and a much larger 10.7 cm intermediate repair to the forearm. The case would be coded 13,000, 120, 12,030. 451 wound repairs involving nerves, blood vessels, and tendons should be reported under the appropriate body system. Example documentation states that a physician repairs a blood vessel in the heart would be coded in code series 35,201, 35,206, and 35,226 direct repair or 35,261, 35,266, and 35,286 repair with graft. Skin replacement surgery codes include surgical preparation and placement of autograft skin from patient or homograft, allograft, and xenograft skin source other than patient or substitute skin source procedures. Skin replacement codes are reported using location and size of resultant defect. Defects in same anatomic area should be added together, while defects in different anatomic sites should be reported separately. In some cases, repairs may be coded separately, i.e., for intermediate or complex repairs. Adjacent tissue transfer codes are also reported separately 14,000 minus 14,061. Most micrographic surgery is performed when complex skin cancer requires removal and is reported only when the surgeon and pathologist are working together in two separate and distinct roles. Repairs and biopsies performed on the same day as a MOS procedure should be reported separately. Modifier minus 50. 9 should be reported on any subsequent procedures performed to report that services are distinct and separate as documented by the provider. Breast biopsies and other procedures of the breast are reported using codes 19,000 minus 19,499. Musculoskeletal system surgery guideline surgeries performed on bones, muscles, tendons, joints, ligaments, and bursae are reported in this section. Procedures related to fractured or broken bones are reported utilizing the appropriate type of surgery classification used to repair the bone. These classifications are defined below. Open treatment procedures are reported when the surgery requires open procedure to repair the bone. The open procedure allows the bone to be seen by the surgeon so that repairs can be performed. The open treatment may be performed at the actual site or may be indirectly visualized by performing a remote repair away from the site, where the bone is not directly visualized through the actual site. Closed treatment procedures are reported when the fracture treatment does not require open surgery to repair. Closed treatment procedures may be performed with manipulation, without manipulation, or with traction, without traction. Manipulation is when the bone is moved back into its original place after separation without the need to perform an open procedure. Frozen shoulders, neck, back, and knee replacements can also be manipulated back into place when popped out of joint or out of line. Traction is used to apply force to draw two adjacent bones apart from one another so the joint space in between can be expanded. Traction can also stretch the soft tissue around the joint. Traction is provided manually or by means of a device. Percutaneous fixation is used to treat a fracture by placing fixation devices such as pins across the fracture site, usually under X-ray imaging. Spine procedures are reported by anatomical site and by vertebral categories including cervical, thoracic and lumbar, sacrum and coccyx areas. Each spinal column has a certain number of vertebrae within each code classification. Cervical 7 vertebrae C1 C7 thoracic 12 vertebrae T1 T2 lumbar 5 vertebrae L1 L5 sacrum 5 fused vertebrae S1 S5 coccyx 4 fused vertebrae coccyx. When coding for these procedures, each vertebrae is counted as one individual vertebra. For example, a procedure performed on C73 would be a total of 4 individual vertebrae. A procedure performed on L1 L3 would be 3 total vertebrae, and so on. The total number of vertebrae within each classification and the designation for each as described within the CPT procedure code. Descriptions are shown in the diagram on the next page. Interspaces are counted and reported as one interspace between each vertebra. Interspaces will be discussed in more detail within the neurosurgery section. Osteotomy codes are used to report procedures involving cutting of a bone or removal of a piece of bone. When performing osteotomy procedures, arthrodesis, instrumentation, and bone graft procedures are all reported separately. Arthrodesis is the fusion of joints by surgical intervention performed for the purpose of reducing or eliminating pain. Other procedures performed and reported within the musculoskeletal section include arthroscopies and injections. Respiratory system surgery guidelines. Respiratory procedures include procedures performed on the lungs, tracheae, bronchi, alveoli, nose, and mouth. Procedures in this section include repairs, foreign body removals, biopsies, and endoscopies, i.e., bronchoscopies, laryngoscopies. When reporting diagnostic procedures, it is important to remember that the diagnostic procedure code is included in the primary surgery endoscopy when performed within the same session. Diagnostic procedures should only be reported separately if the diagnostic procedure is the only procedure performed and no additional surgical intervention is required. Endoscopic surgery refers to looking inside the body for medical reasons using an endoscope. An endoscope is an instrument used to examine the interior of a hollow organ or cavity of the body. The instrument and video equipment used to provide live images are displayed. Images are produced from the camera on the end of the scope. Below are pictures of respiratory endoscopic procedures performed utilizing the scope for the larynx and the nose. Note that the patients are generally awake during these procedures and are able to communicate with the physician. Cardiovascular system surgery guidelines. Invasive surgery within the cardiovascular system is reported using code series 30 377,799. The radiology section of CPT is used to report the images that are produced when invasive procedures are performed. Diagnostic procedures on the cardiovascular system are reported in the medicine section and will be reviewed in detail in Chapter 10 of this manual. The cardiovascular system includes the heart and two vascular systems, the arterial and vascular. These systems are responsible for blood transportation throughout the body. The arterial system transports blood to lungs and peripheral away from center or outside organs of the body. The vascular system transports blood back to the heart and from the lungs to the heart. CPT procedure descriptions for the cardiovascular system are reported by the type of surgery performed: repair, excision, incision, and the anatomical area where the surgery is being performed: heart, vein, artery. The heart's two upper chambers, called the atria, contract. This contraction pumps blood into the heart's two lower chambers, the ventricles. The ventricles then contract and pump blood to the rest of the body. The combined contraction of the atria and ventricles produces a heartbeat. There are a number of subsection procedures that describe the various types of surgery and locations where surgery is performed to assist in reporting major surgery within the cardiovascular section. The key operational subcategories include the following: heart and pericardium around the heart 33,000 and 10-30. 3,999 arteries and veins 34,000 and 1-37,790. 9. There are specific guidelines and requirements that must be followed to appropriately report procedures within the cardiovascular section. The guidelines and the subsection instructions for each area are discussed below. Pacemakers are small devices that are implanted under the skin in the area of the collarbone or under the abdominal muscle just under the ribcage. The pacemaker assists the heart to maintain a regular beat when the heart rate is too rapid or too slow. Wires are attached to the pacemaker and hooked to the heart. The pacemaker equipment consists of the pulse generator, which includes the battery, electronics, and the electrodes or leads. Implanted pacemakers are reported using codes 33,212-33,214. When a pacemaker is placed temporarily, they are generally planted outside of the body. A battery is attached to a belt to run the pacemaker. Code 33,210 is used to report a temporary pacemaker. The pacemaker works by generating an electrical charge to the heart when the heartbeat is irregular so that the heartbeat is controlled and properly maintained. The illustration below shows how a pacemaker is inserted and where the various components reside once implanted. Pacemakers are inserted for less serious heart arrhythmias that is generally not life-threatening. Pacing cardioverter defibrillator ICD is an implantable cardiac device that uses a shock to control heart arrhythmias, primarily those that may cause cardiac arrest. ICD equipment consists of the pulse generator with wires containing electrodes on the ends that connect to your heart chamber's eye. CDs are reported using codes 33,000, 33,264. If the ICD device detects an irregular rhythm in your ventricles, it will use low energy electrical pulses to restore a normal rhythm. If the low energy pulse not restore normal rhythm, a higher energy pulse is activated. An ICD would be inserted for more serious heart arrhythmias, and those arrhythmias that are generally life threatening if not treated. The illustration below shows an ICD and how the components work when inserted and the patient has an arrhythmia. Pacemakers and ICD procedures are reported by type of surgery: insertion, replacement, upgrade, repositioning, repair, and revision. Internal or external placement, equipment being inserted: generator, leads, type of pacemaker: single, dual, or biventricular, and the number of leads utilized: single, dual, or multiple leads. There are three pacemaker systems: single chamber, dual chamber, and biventricular pacemaker systems. The single chamber pacemaker utilizes one lead positioned in either the upper or lower chamber of the heart. The dual chamber pacemaker utilizes two leads, one positioned in the lower and one positioned in the upper chamber of the heart. The biventricular pacemaker utilizes three leads. One lead is placed in the right atrium, one is placed in the right ventricle, and one is placed in the left ventricle of the heart. For biventricular pacing, the left ventricle may require an additional electrode placement to ensure appropriate pacing. In this case, transvenous placement of the electrode is considered a distinct and separate procedure and should be reported separately using codes 30, 3224 or 33,225. The first diagram below shows each type of pacemaker system described above: single, dual, and biventricular, where they are implanted within the heart, and the equipment utilized for implants, including the pulse generator and leads. A comparison of the pacemaker and ICD implant is shown in the illustration below. National Institutes of Health. Note the difference in the size and shape of the pulse generator for the defibrillator and pacemaker, the number of leads that are extended from each generator, and the placement of the electrodes within the heart to provide a shock to the heart when the patient's heart rhythm is compromised. Figure A shows the location and general size of an ICD in the upper chest. The wires with electrodes on the ends are inserted into the heart through a vein in the upper chest. Figure B shows the location and general size of a pacemaker in the upper chest. The wires with electrodes on the ends are inserted into the heart through a vein in the upper chest. Radiological procedures performed with pacemaker or ICD procedures are not reported separately as they are considered as an integral part of the procedure to determine correct placement of the device. Radiologic procedures performed in the absence of performing an insertion, replacement, or revision may be reported separately. If fluoroscopy is reported in addition to the diagnostic radiology procedure, code 76,000 should be reported. When coding pacemakers and ICDs, the following information regarding leads should be used to ensure accurate assignment of the code. Single lead is reported when a pacemaker or ICD is placed in only one chamber of the heart. Dual lead is reported when a pacemaker or ICD is placed in two chambers of the heart. Multiple lead is reported when a pacemaker or ICD is placed in three or more chambers of the heart. A lead is a soft, thin, insulated wire connected to the pacemaker or ICD device. Leads carry the electrical pulse from the device to the heart, and they carry information about the activity of the heart from the heart back to the device. One end of the lead is connected to the device and the other end is attached to the heart. Coronary bypass grafting codes are reported by type of grafting performed. For venous grafting, codes 33,510-33,516 are reported. Combined arterial venous grafting is reported using codes 33,517-33,516 530 and arterial grafting is reported using code series 33530. 3-33548. Coronary artery bypass graft CABG is reported in this code series 33530. 3-33536 35600. CABG procedures repair the existing lesion region in organ or tissue that is damaged through injury or disease as well as addressing future lesion development. To report venous CABG procedures, refer to code range 33,000. 510-33,516. Arterial CABG procedures are coded within the code series 33,533-30. 3,536. The following CPT level II codes may be reported in addition to the appropriate CPT procedure for data collection purposes. These codes should not be reported as standalone codes. 4110F internal mammary artery graft performed for primary isolated coronary artery bypass graft procedure. 4110F on P documentation of medical reasons for not performing an internal mammary artery graft for primary isolated coronary artery bypass graft procedure, e.g., not indicated, contraindicated. Other medical reason. 4110F fight P internal mammary artery graft not performed for primary isolated coronary artery bypass graft procedure. Reason not otherwise specified. Percutaneous coronary intervention and CABG procedures are shown in the illustration below. The PCI is performed using a stent, whereas the CABG reroutes or bypasses the area that is blocked to a healthy artery with no lesion or defect. Endovascular repair of descending thoracic aorta are reported using code series 33,880-33891. These procedures are used to report endovascular grafting repair of the descending thoracic aorta. The following services are inclusive of the endovascular repair code procedures and should not be reported separately. Introduction of any devices, manipulation, manual treatment, positioning, deployment, balloon angioplasty, stent placement services that can be reported separately include arteriotomy exposure and closure 34,812, 34,820, 34,833, 34,834. Guide wires and catheters 36,100 minus 36,140, 36,000. 200 minus 36,218 extensive repair or replacement procedures of the artery 35,226, 35,286 and transposition of subclavian artery 33,889, 33,891. Fluoroscopic codes should be reported separately using appropriate codes from series 75,950. 6-75,959. Additional interventional procedures should be reported separately as well. Heart and lung transplants are reported using procedure code series 33,930-30, 3,945. There are three distinct surgical components included in the surgery procedure definitions. Each component is defined below. Each must be appropriately documented for accurate code assignment. Cadaver donor cardiectomy, with or without pneumonectomy, including harvest, allograft, and preservation, code 33,930, 33,940. Backbench, including preparation of cadaver donor heart and lung allograft prior to transplant, 33,933, and preparation of cadaver donor heart allograft, 33,944. Recipient heart with or without lung allotransplantation, 33,935, 33,945. Ventricular assist devices VAD are used to assist a weakened heart to work normally. There are two main types of VAD devices: left ventricular assist device LVAD and right ventricular assist device or VAD. When both the LVAD and RVAD are used, it is referred to as biventricular assist device BIVAD. VIDs may be external devices primarily short term used pre and post operatively, or internal implanted devices primarily used temporarily while awaiting replacement or permanently when replacement of heart is not an option for treatment. The illustration below shows what the difference is between the internal and external devices and the equipment used for each, including the control unit, batteries, and cables. The process for how the device works is shown in illustration B. The LV assist device pumps blood it receives from the ventricle to the aorta in the example shown. VAD procedures are reported using code series 33967 33993. VAD procedures are categorized by procedure type and include insertion, removal, repositioning, and replacement procedures. Surgical insertion of cannula is reported separately using code 36823. When performed, an open arterial exposure is reported separately using code 34812. To report repair of aneurysms of arteries and veins, use codes 34800 30, 4834, 34900 35152. An aneurysm is a bulging or enlargement of an artery caused by weakening of the arterial wall. If left untreated, aneurysms grow until they pop, causing severe damage or death. When coding aneurysm repairs, the site of the aneurysm is critical. In the cardiovascular system, abdominal aortic aneurysms AIA, femoral aneurysm, and iliac aneurysm repairs are reported. A pseudoaneurysm, false aneurysm, is a blood clot that forms from a leaking hole in the artery. Pseudoaneurysms are reported within the aneurysm repair code section. The pseudoaneurysm grows on the outside of the arterial wall, whereas an aneurysm grows among all layers of the arterial wall. Aneurysm procedures of the brain are reported within the nervous system procedure area. Abdominal and thoracic aortic aneurysms left and an actual abdominal aortic aneurysm revealed during an AAA procedure right are shown in the illustrations below. Bypass grafts excluding CABG are reported using codes 35500 35671. Bypass grafts are performed to allow an alternative route for blood flow around a blocked artery. Vascular injection procedures performed invasively are reported using code series 36000 36680. Vascular injection procedures are performed for the purpose of treating aneurysms, for injections for venography, and for visualization or diagnostic purposes. Vascular injection procedures are further categorized by location of catheter placement. Intravenous codes are reported in code series 36000 36015. Intra-arterial and intra-aortic codes are reported in code series 36100 36299. Venous codes are reported in code series 36400 36598, and arterial codes are reported in code series 36600 36660. Placement of needle for intraosseous infusion is reported using code 36680. Local anesthesia, introduction of the needle or catheter, and pre and post operative care are all included in the procedure and therefore are not reported separately. Catheters, drugs, and contrast material are reported in addition to the vascular injection procedure. Radiology supervision and interpretation codes should be reported separately utilizing codes in the radiology section. Catheters are introduced into vessels for a number of different purposes, including monitoring blood draws, injection of contrast material, and infusion. In order to accurately code catheter placement, it is critical to understand where the catheter starts and where it ends. To understand how to determine the beginning and ending point of the catheter, an understanding of how a vascular family is constructed is required. A vascular family has a main trunk from which other smaller vessels branch out. Vessels connected to the main trunk are called families. There are a total of 5 vascular families: systemic, arterial, systemic, venous, pulmonary, portal, lymphatic. Catheter placement is designated in the CPT description as non selective or selective. Non-selective catheter placement means the catheter or needle is placed directly into an artery or vein and not manipulated farther along or is placed only into the aorta from any approach. Selective catheter placement means the catheter must be moved, manipulated, or guided into a part of the arterial system other than the aorta or the vessel punctured, that is, into the branches, generally under fluoroscopic guidance. When coding selective placement for any procedure, you report the furthest extension into one vascular family. The first order is the main artery in a vascular family. The second order is the branch off of the main artery. The third order is the next branch off the second order, and so on. A vascular family can have more than one second order, third order, and so on vessel. If the farthest extent of the placement was to the third order, only the third order code would be reported because the catheter had to go through the first and second order within the same artery to get to the third order branch. Example: if a catheter is placed into the first order brachiocephalic artery and from there manipulated through the second order artery and finally into the third order artery, you would report only the third order artery with code 36217, which describes an initial third order placement within the brachiocephalic family. The following additional vascular access guidelines should be considered when coding for invasive catheterization procedures. If a single access catheter puncture site is established, selective catheterization should be coded over non-selective catheterization. Only the highest order of one family should be reported. If other second or third level catheterization is performed within the same family, the add-on code should be reported. Code for each vascular family accessed. Code for each vascular access. Use codes 36,215 minus 36,218 when reporting procedures above the diaphragm. Use codes 36,245 minus 36,248 when reporting procedures below the diaphragm. Pulmonary angiography involves right and left pulmonary arteries representing two vascular families. When coding for selective catheterization, the following guidelines related to vascular families apply. Primary equals the first turn off of the main trunk aorta. First order vessels include innominate brachiocephalic artery, left common carotid, and left subclavian. Secondary equals second turn off of the main trunk aorta. Second order vessels include the right common carotid artery, left external carotid, and left vertebral aorta. Tertiary equals third turn off of the main trunk aorta. Third order vessels include right external carotid artery and right vertebral artery. Use the below selective catheterization guidelines to ensure accurate reporting for these services. From a right femoral access, code the selective catheterization of the right renal artery using code 36,245. From a right femoral access, code selective catheterization of the left external carotid and the left vertebral arteries using codes 36,216, 36,216 minus 59 from a right femoral access. Code the selective catheterization of the right vertebral artery and the right internal carotid artery using codes 36,217, 36,218. Code series 36,200 minus 36,218 can be reported using the chart below. Central venous access CVA procedures are performed for the purpose of drawing blood or giving medications or nutrients without being subjected to multiple needles and different access points for obtaining or giving such care. Access devices include subcutaneous ports, pumps, or catheters inserted externally. There are 5 surgical categories for CVA procedures defined within the code descriptions. Insertion placement through new venous access repair device fixed without replacing device, partial replacement, replacement of catheter only, not entire device, complete replacement of entire access device through single access point, removal of entire device. Report each individual access point separately. Imaging services are reported separately using code 76,937 and 77,001. Endovascular revascularization procedures are performed in order to restore blood supply interrupted after a wound or injury. Codes 37,220 minus 37,235 are used to report these services. There are 3 arterial vascular territories where these procedures are performed. Iliac vascular territory includes common iliac, internal iliac, and external iliac territories. Single primary code is used to report initial iliac artery treated in each leg, code 37,220 or 37,221. Other iliac vessels treated in the leg would be reported with add-on codes 37,222 and 37,223. A maximum of two add-on codes can be reported since there are three vascular territories and therefore up to three vessels that may be treated. Femoropopliteal territory includes one lower extremity reported using codes 37,220, 37,227. Single code is reported for territory including common, deep, and superficial femoral arteries. There are no add on codes to report since the one extremity is counted for the entire territory. Tibial peroneal territory includes anterior tibial, posterior tibial, and peroneal arteries. A single primary code is reported for initial tibial peroneal artery treated within each leg using codes 37,228, 37,229, 37,230, or 37,231. Other tibial peroneal vessels treated should be reported using the appropriate add on code. A maximum of two add on codes can be reported since there are three tibial peroneal territories within each leg and therefore up to three vessels that may be treated. Transluminal balloon angioplasty is reported utilizing codes 37,220 minus 37,222. Thank you so much watching my video.